Okay, we're going to start back in. I'd like to introduce to you Maurizio to talk about his illustrating his rare disease and how his own profession allowed him to get the diagnosis. Thank you very much.
Thank you. Good morning everyone, my name is Maurizio De Angelis and I'm a medical illustrator and 3D modeler based in London. I'm here today to talk about my medical work in relation to some health issues I've experienced in the past. And I'd like to share with you how being a medical illustrator made such a big difference in my clinical case. But before we get into the details of the presentation, I'd like to introduce briefly myself and tell you a little bit about my background. I'm originally from Rome, where I studied figurative drawing and painting, concentrating mainly on the traditional Italian style. And obviously anatomy was part of the studies, and here there are some drawings that I made about 30 years ago. And the numbers here, which are quite clunky, have been all chipped off, were done with transparent water. This is solar central. I started working as an artist when I was still at school, doing small paintings on commission. I was basically trying to sell stuff to my own family, probably try to overcharge them. Then I became a digital illustrator working for an advertising studio until I ended up working for the Italian national television as a scientific illustrator. My first job in medical illustration was in 2002 when I received a very large commission from an Italian publisher to make 265 illustrations of shoulder surgery. And that was the event that basically signed my path as a medical illustrator. Not only because I had a huge portfolio based on medical illustration, but also because it sparked in me a great interest in this fascinating subject. But deep down, I also had a great interest in 3D modeling, which is the practice to create 3D models using dedicated programs such as MAA or ZBrush. So after studying, I chose to specialize in 3D modeling as I wanted to work for the film industry. So in 2004, I decided to move to London and try to break into the film industry as a 3D modeler, and over the last 20 years I worked on major titles for the biggest VFX studios in London, working on films such as Maleficent, 007 Skyfall, The Witcher and many others, which some of them I basically refuse to watch. At the same time, my client base for medical work has grown. I also started my collection on Science Photo Library in 2014, and in 2015 I was one of the 20 finalists for the Welcome Image Awards. I currently work as a freelance medical illustrator for my own clients, and I'm represented for the US market by Way Art in New York, for whom I do this kind of illustrations. So that was probably a too long overview of my background, where I come from and what I do. But as I said at the beginning, the reason I'm here is to talk about how being a medical illustrator and 3D modeler made such a big difference and also contributed to getting a diagnosis. I was born with an exceptionally rare condition called lymphangiomatosis, a disease characterized by abnormal growth of lymphatic vessels and formerly used as an umbrella term for 4 related conditions. Today, lymphangiomatosis has been reclassified under complex lymphatic anomaly, which is CLA, and includes GLA, GSD, KLA, and CCLA. Broadly speaking, these 4 conditions involve lymphatic malformations which can manifest anywhere in the body and lead to severe health complications such as pain, swelling, infections, and lymphatic leakage. Here there's an illustration of some normal lymphatic vessels on the left and an illustration of some lymphatic malformation on the right, so we can see the difference. In my case, I'll focus specifically on GLA and GSD. GLA, which is generalized lymphatic anomaly, affects the soft tissues, bones and organs, and is characterized by a proliferation of lymphatic vessels, sometimes manifesting as a protruding mass. GSD, which is Gorham-Stout disease, mainly affects the bone and is characterized by progressive loss of the hard outer surface of the bone, which is the cortex, and in extreme cases, the complete disappearance of the bone itself, so much so that it was formerly known as a phantom bone disease. To make matters more complex, these conditions can overlap, further complicating diagnosis and treatment. And clearly, these complications have a profound effect on patients. So between the ages of 3 and 7, here I'm the one on the left, my occurrence noticed a small mass that was getting bigger and bigger around my left armpit and pectoral muscle. At the time I was living in Rome, not too far from the Ospedale Pediatrico Bambin Gesù, owned by the Holy See, which is the Vatican, and is a very important hospital, similar to Great Ormond Street Hospital in London. I was diagnosed with lymphangiomatosis in 1984, which is quite exceptional given the rarity of the disease. And after 2 operations over the course of 3 years, a part of my muscle around my chest and armpit were removed. When I was about grumpy 15 years old, I began to complain of some pain in the back of my skull, a very peculiar pain similar to a blue mark on the skin, and also started to have the impression, which is a key word, that the shape of my head was somehow changing. I understand that it might sound peculiar, and it sounded peculiar to doctors as well. Fast forward, when I was about 30 years old, sorry about my shorts there, I'm not sure why I popped them at the time. The vault of my skull started to erode. Some round dents formed at the top of my head, with a lot of pain associated with it. So in early 2015, I went for a CT scan and then an MRI. But while the CT scan report showed a number of erosions and recommended further investigation, the MRI came back with a report that astonishingly said, conclusions, normal examination, no bony lesions are identified. If we now focus the attention here, where the red circles are, we can clearly see that the thickness of my skull is decreasing dramatically. In fact, the cortical bone in that area has disappeared. I still found it very peculiar that a radiologist could not see an anomaly there, but just to put things in perspective, I spoke to a retired orthopedic surgeon with 40 years experience in the field, and in his professional career, he only saw 2 cases of GLA or GSD. The problem now is that if a medical report says normal examination, the health system will treat you as such, as someone who does not need any treatment. So getting to a diagnosis was very challenging because it was also very difficult to convince the doctors that something was actually happening, and it wasn't just my impression. And this is where my skills as a medical illustrator and 3D modeler came in quite handy. After 3 scans done over 3 years, I decided to request the CD with the images on it. And this is part of the patient's right. So generally speaking, it's always worth requesting these CDs after some scan. CT and MRI scans produce a large number of images called slices. So if we imagine the scan going from the top of the head to the bottom, we would get a number of slices done. And the distance between 2 slices can vary from scan to scan. Sometimes it's only 2 millimeters, so there's a lot of data inside these slices. Normally, this series of images is called DICOM. That comes from the file extension name. Right, so there's some software where you can import this DICOM series and get a 3D model based on the density of the tissue. The software I use is 3D Slicer and Invisalus, and they're both free to use. So how do they work? For instance, there's a huge difference in density between bones and fat or muscle tissue. So it's easier to extrapolate the skeleton, which is clearly very dense, from the soft tissue. And there's also a huge difference in density between the surrounding so the atmosphere and the skin. So the outer shade is also translated really well. You can actually see the texture of my skin. Obviously, things can get a little tricky as the density between soft tissues are more or less similar. My aim was to prove to the medical professionals that my head was changing shape, and because I'd been moved from one hospital to another, there wasn't really one place where my case could have been looked into more details. So what I did was to extrapolate the DICOM series from each examination and convert the result into a 3D model to show firstly the erosions and secondly a progression. So if we now compare two CT scans done in 2015 and 2016 and we focus on the erosions, we get closer, we can see a difference. Especially around these erosions here, left to right, we can see a progression that the lesions are spreading. So basically I extrapolated and converted the data for 2016, 2017 and 2018. And here you can see the back at the top and the top of my head all lined up. If we now compare the 2015 scan with the 2018 scan, we can see a clear progression. Apart from 2 or 3 spots where the lesions have completely perforated the skull, the majority display a clear characteristic. In the red circles area, the lesions have destroyed the outer cortical and trabecular bone, while the inner cortical bone remains largely intact, which is obviously great for me. So if we take a look at the colored illustrations on the right, it's easy to understand the kind of activity I'm referring to. We can actually see that the disease has affected the outer cortical bone, the trabecular bone, but the inner cortical bone is still intact. Regarding full perforation, there are some area of concern, particularly these 2 spots here, one at the back and another one at the right temple. In both cases, the outer and the inner cortical bone, as well as the trabecular bone, have been completely destroyed. So this means complete perforations compared to before. I was given the option of having a bone biopsy to understand a little more about the condition, which was still a mystery to me and to the doctors. However, as the skull was already quite compromised, they decided to take only a small fraction of the cortical bone. Up until that point, I had no reason to suspect there was a link between my chest-arm condition, which was related to a soft tissue, and to my head, obviously, to the bone. But one line in the biopsy report changed everything for me. The report stated, in the settings of lesions elsewhere, lymphangiomatosis should be considered. And I clearly had lymphangiomatosis when I was a child. But because the sample collected from the biopsy was too small, a diagnosis was not possible from this sample. But given how rare these diseases and considering the pathologist in London was unaware of my own medical condition, that I had surgery in another country 30 years before, it seemed more than plausible to me that it was indeed lymphangiomatosis. This led me to meet Professor Peter Mortimer, consultant dermatologist at St. George's University Hospitals, with whom I had a very intense and productive discussion, during which I showed him all the illustrations work that I had done to support and document my case. He agreed that lymphangiomatosis was a strong possibility, and for the first time, a medical professional listed the following possible diagnoses. 1. Lymphatic vascular anomaly. 2. Gorham-Stout disease. 3. Lymphangiomatosis. It's worth noting that today, lymphatic vascular anomaly and lymphangiomatosis, so basically the first and the third diagnoses, are now referred to as generalized lymphatic anomaly, GLA, while Gorham-Stout disease is classified separately. But even less than 10 years ago, this distinction wasn't so clear. With their diagnosis in hand, Professor Mortimer was able to refer me to the sarcoma unit at the Royal Marsden Hospital in Fulham, saying in the referral letter, Maurizio, the patient, is very on top of his history and his circumstances. To be honest, by that point, I almost had a nervous breakdown, as navigating the healthcare system with a rare disease can be incredibly challenging, but yes, I was at least on top of my history, which clearly helped. Landing at Royal Marsden Hospital was rather promising, as 2 other patients have been seen in the past. I quickly found out that there is no known cure for GLA or GSD. The only treatment available was a drug called sirolimus, which is an immunosuppressant. Sirolimus is also known as rapamycin, a compound found in the soil of Rapa Nui, which is East Island. So an extremely rare disease treated with a compound found on a remote island on the Pacific Ocean. Just incredible. I began taking sirolimus believing I had finally found the best solution I could have hoped for. However, during an initial assessment at the Royal Marsden, a number of scans were made and doctors discovered another abnormality, even this time inside my left femur. I believed the hard times were over, but little did I know that this new problem would affect my life so much that it would leave me with a walking impairment and a chronic pain condition. A rather large mass was found in the cartilage area of the femur, which can be seen in yellow. You can see a scintigraphy on the left and an MRI on the right. Apparently, in modern oncology, it's not possible to differentiate the type of bone tumor from MRIs, CT scans, or even from biopsies. This means that this mass could have been an enchondroma, which is a benign tumor, or a chondrosarcoma, which is a rare malignant tumor. I was urgently referred to the Royal National Orthopaedic Hospital in Stanmore in North London for further testings, and Mr. Rob Pollock, consultant sarcoma surgeon, who was in charge of my case, told me, "We can't really say whether it's cancer or not, but if it's cancer, there's a risk of metastasis. But if it's not cancer, the femur will eventually break as the mass grows and puts pressure on the inner walls of the bone. So your choice is to wait and see, or to have a part of your femur removed." A bit of a gamble, basically. After much consideration, we decided that it would have been wise to have an operation. And if there was anything really difficult, was to fly into Rome over the Christmas period and tell your parents that you might have cancer, but that you have to go through surgery anyway. It's a terrible thing to say to your loved ones. So the plan was to resect the proximal femur, highlighted in red, which was then calculated to be 22 centimeters or 8.5 inches, then remove the entire joint and replace it with a titanium prosthesis. So this is not a hip replacement, this is a proximal femur replacement, which is a totally different thing. And this is an X-ray on the right showing the prosthesis put in place after surgery. The histology confirmed that it was a grade 2, possibly 3 chondrosarcoma, meaning cancer. So I think we made the right choice in the end. A few months after the operations, I gathered all the data from Stanmore and began reconstructing myself in 3D. Why not? The main reason for this was that the technical details of the surgery had never been fully explained to me, and I wanted to understand my condition better. And also because one particular component from the prosthesis was causing me a lot of pain after I suffered a fall just 4 days after surgery. In order to rebuild myself, I studied the actual prosthesis offered by Stanmore Implants, where several key parts can be identified. Then my plan was to extrapolate the data of the implanted prosthesis, but I didn't consider that the prosthesis, being metallic, would reflect the beams from the CT scan and create a lot of noise around the area, as you can see at the bottom. So all that noise is because of the rays reflecting from the prosthesis. So the only options was to remodel the prosthesis from scratch in MAA, and here on the right you can see a generic colored view, and next to it a 3D rendered view with a metallic shader applied. So the ones on the right are 3D models, and that clearly is the reference. The next step was to extract the body parts, and I used for this a CT total body scan as the source. I started by extracting the outer skin of the legs and then moved on to the skeleton. But you can see that the extraction wasn't perfect, as it was catching all the noise coming from the kidneys and the arteries. So after cleaning and fixing the skeleton, I finally put the newly modeled prosthesis in place, matching the position against the X-ray. So we can see the 3D model, and basically I matched the position using the real reference, that was the X-ray. And these are the final images I produced. I wasn't looking for a photorealistic effect, but a clearer illustration where the elements are easy to see and understand. And that's usually the scope of medical illustration, which is to make subjects readable and comprehensible. The hips play a vital role in our mobility, and at the proximal end of the femur, several essential muscles enables us to stand, walk, run, bend, and sit. During my surgery, most of these muscles had to be detached from the bone, and as you can imagine, this is a major operation that can really affect your life and also give you the ability to return to a normal life after surgery. In light of this, the surgeon's plan was to preserve the trochanter, which is the bony prominence to which a number of important muscles, such as the gluteus and the piriformis, are attached. After the resection, the greater trochanter was secured beneath the attachment, and this would have significantly improved my ability to walk. As we can see in the image in the center, the gluteal muscle is still naturally attached to the greater trochanter, which is then held in place by the leg, which is also highlighted in blue. Unfortunately, after a fall, the trochanter snapped off from its attachment, and in the X-ray on the left, you can see in two separate parts labeled A and B. It's a little bit faint, but it's there. The unpolished extracted model on the right also shows the break, and while it's not perfect, you can still distinguish the two parts. These illustrations hopefully make it clearer. In the before image, the trochanter is securely locked under the plate, while in the after image, you can see the trochanter has broken off and the muscle has retracted. In this new scenario, the attachment no longer served any purpose. It was a redundant part, and in fact was causing me a lot of discomfort, as the tendons constantly rubbed against the plate and the two pins whenever I moved. I knew I had to fight the system somehow, as articulating exactly what I was experiencing and persuading the surgeon to take action at the same time proved to be incredibly challenging. But with the help of the illustrations, I managed to be very convincing. And in the end, Mr. Pollard, who is an amazing and incredibly talented consultant, to whom I am very grateful, understood the implication that a simple plate and two pins could have me for the rest of my life, so he decided to remove them. And here you can see a before and after image, so I clearly have removed that bit. So I had another surgery, and overall I can say that from the first operation I had in 2018 and the second one in 2019, it took me about 4 years to recover to a level where I can say I am leading a sort of a normal life, whatever normality means. I'd like to conclude this presentation with this final illustration, which is a mix of medical artwork and sci-fi effects. It shows me undergoing a scan with this laser-like effect projected across my face, suggesting the imaging process. MRI scans can take up to 30 minutes, and given that I have quite a few of them, they actually turn into this weirdly peaceful time to think about art, come up with ideas, or just relax a bit. What I hope you take away from this presentation is that being a medical illustrator has profoundly shaped the way I've navigated my own health journey. In fact, illustration became a tool not just to document, but to communicate. I used it to engage with medical professionals, to prove my point, and help them better understand what I was experiencing. After all, that's the real purpose of medical illustration, to translate complex concepts into something clear and comprehensible. And with this, my talk comes to an end. Thank you all for listening. I understand it's been quite dense, too fast, but that's the work.
Yeah, question.
Yes.
Well, not so much a question, Maurizio, but more one of
That's something. Yes.
one more of just sheer applause. It's so wonderful when you still see real life effects like this, and we rarely get these sort of talks at our conference. There's one other I remember many years ago of a medical artist who wanted to work with a surgeon who refused to have her in this theatre with him, but she persisted for months on end, and in the end she won him round, and he insisted she was always there. And it's these live stories that make such a difference. I mean, your artwork is absolutely outstanding.
Thank you.
And I think, and I'm sure all my other fellow MAA members are so glad you're now one of our members.
Thank you so much.
An absolutely brilliant presentation. Thank you very much, and thank you for sharing such personal detail. My question is, these complex lymphatic problems that you described, the 4 varieties that you mentioned, when were they first described? And I ask the question because many years ago, I myself was involved working for a professor of surgery who was the then leading authority in this country on diseases of the lymphatic system. And I wrote a chapter in his book on a particular aspect which I was interested in, and that these diseases were not mentioned in his book at all.
Yeah.
And I wondered when this developed and how recent it is that this knowledge has become, if not widely known in the medical profession, at least known to some in the medical profession.
Yeah, apparently there are 200 cases in the medical literature up until the 90s.
In the 90s?
In the 90s, basically. And
Yes.
now the number have grown a little bit because of the internet. So people like me can connect to others. There's a Facebook group where we can communicate, we can share experiences, and the main problem is getting a diagnosis, because as I was saying before, even doctors with 40 years experience, they didn't have any other cases or patients, so there's a very small literature about, so that's why it's challenging.
Well, I'm relieved that it was in the 90s, because the book that I mentioned, which went into two volumes, was published in the 1970s and early 80s, so it was not known at that time.
Yeah.
So I forgive the professor of surgery.
Anybody else? A question? Yeah.
I was just wondering, because what's amazing is that you, of the patient, that you had this access to a skill set that not all patients obviously have access to, and whether or not you've been contacted by any other patients as an advocate for them to create the illustrations. Is that something you ever thought about getting into? Because there's people out there who don't have your skill set and wouldn't be able to get that across to their
Sure, yeah. In the Facebook group, I helped 2 other patients in the States, and basically I received the CT scans from the patients, and I done all the work that I've done for myself. So I converted all the images, and I basically sent back the illustrations, and I said, go to your doctor so you can point out the specific problems. And yeah, so also the problem is that the radiology department should be able to do that, but because these diseases are not well known, sometimes, like in my case, the MRI was completely missed, either basically a hole in my cranium, and the doctor didn't see it because I'm not the reason.
Yeah, I was going to say, did you feed back to the radiologist the original report? Because anyone looking at that scan would say that is not a normal scan.
We tried, but we didn't have any response.
Yeah.
But we tried. Yeah, but Professor Mortimer was quite surprised to have a patient who's also a medical illustrator, and obviously it's also great for doctors to have this kind of resources.
Yeah,
it's great for doctors to speak to patients that can understand, and so the communication was very prolific. Yeah.
Suzanne, next.
Just a few words from a radiologist. Great job, perfect. It was taskful for the radiologist to ask for previous conditions, and also for previous images, and also the comparison, and also the 3D. CT has been done to look for the bony changes. The MRI has been done to look for soft tissue changes that cause these bony changes. So the sentence you showed is wrong. There were bony changes, but the MRI radiologist should have had the CT images to refer for the specific lesions and to add the comment, so no additional software tissue lesions are there.
Sure.
So just, I had to say.
It's totally understandable.
Yeah, it's an absolutely inspiring talk, and wonderful images, and congratulations on this wonderful research you've done on yourself, and helping other people with it as well. I just wondered, the medication you received from that island, did it regrow your bone tissue? Or
No. The main problem is that because it was an immunosuppressant, as soon as I received the treatment, I also had very annoying side effect apart from that. That I actually had to stop it because of cancer. So basically that drug would facilitate the probability of having metastases, because obviously it is an immunosuppressant, so I had to stop it. But in a way I'm glad that I stopped it, because it was a very annoying side effect, so I couldn't tolerate the drug too well. So yeah, it didn't supposed to regrow the bones, just to stop the condition to go forward.
It's possibly a very ignorant question, but I was just wondering, as the section that was holding your muscle in place snapped off, have they attempted to redo that in any way?
No, they
or
can't
are
do
your
that.
muscles completely
No,
detached?
because it's a very strong muscle, and
Yeah.
they say once is basically once he retracts, he's not able to put it back together. So I have this limp, and I suffer from chronic pain, but that's how also part of my journey. So it's,
Amazing.
yes.
So interesting.
Can we have a round of applause?
Yeah. Thank you.